In today's video, we're going over my favorite intermediate exercises for patients with knee pain. Hey guys, this is Dan from Fitness Pain Free. I'm a physical therapist and coach. We help to make incredible coaches and clinicians through our online courses, mentoring programs, and communities. My goal for you today is to make you 1% better. All right, so we all know the exercise is really helpful for folks that have knee pain. This goes both for non-op patients, so let's say someone has patellar tendinopathy, we know exercise can be beneficial for those folks. We also know it's beneficial for folks that just had surgery. The problem is when you have a post-op patient or non-op patient, if we do things that are way too easy, we might not get the effect that we want. If we go way too hard, worst case scenario, we end up damaging that surgical site or we just flare someone up. So at the end of the day, we have to meet them in terms of tissue irritability. So in the last video, we ended up going over a basic exercise for patients that have knee pain. If you haven't seen that video yet, I recommend checking it out. I will leave a link in the show notes in the description below, and then get back to this video. So one of the first principles to keep in mind when we're going from this transition to basic to more intermediate is we're starting to increase the loads that people use. So in phase one, we're doing partial body weight, TRX assisted, kickstand, getting a little help for the involved side with the uninvolved side. When we progress to a more intermediate stage, we're using more full body weight, and on top of that, we start to introduce load. And we do this in a variety of different ways. My chosen implement of choice is either going to be a dumbbell or a kettlebell. And the reason why I like dumbbells or kettlebells over, let's say, a barbell back rack is because you're going to be limited with how much weight you can use based on your grip or how much you can hold out in front of you, right? So a good example, go ahead and grab one of those kettlebells, Kylie, and just hold this in a goblet squat position, right? So if I have an athlete that can squat 200 or 300 pounds with a barbell on their back, they're not gonna be able to hold 200 or 300 pounds right through here, right? So this is a bit of a limiting exercise in terms of how much weight we're using, simply because it's harder to hold, right? If this is a little too easy, we can also try a kettlebell front rack with two. So now we have two kettlebells, and this increases the load, right? The other way I like to increase load is through a contralateral load. So essentially, let's have you just put one down, and let's do a split squat, and we'll have the right side leg forward, left back. So in this exercise here, we have a kettlebell on just one side. One kettlebell, obviously a little less weight than two kettlebells. The other reason why I like these contralateral loads is because the weight is trying to pull us towards the floor, and we have to fire the glute medius on this front side leg a little bit more so. So we get a little bit more work for that front side hip when we're doing a contralateral load. And once your athlete is ready for it, we can just grab two kettlebells here. Excellent, and give me a regular split squat. Good. So now we're increasing the load even more. The other piece is that at some point, you're gonna be limited by your grip strength for most athletes. So in the advanced phase of rehab, we're gonna switch over to more barbell work on the back or the front rack. But for now, kettlebells and dumbbells are the way to go. The next thing we tinker with is going to be range of motion. So in the beginner stage, we're more often doing partial ranges of motion. We have a big weight shift back, so we have minimal knee bending when we're doing something like a squat, and that reduces some of the strain on the knee. As we get to the more intermediate phase, we're starting to increase ranges of motion. So when we do our split squats and lunges, we're usually going all the way down towards the floor, and for our squats, we're usually going to about parallel or maybe slightly below that. The next variable that we're going to mess around with is going to be your weight translation when we're doing things like squats, lunges, step up, so on and so forth. So in the first instance, I'm gonna have Kylie here squat, really setting her hips back, and then when you get to the bottom, just pause for me. So if you watch her squatting from the side, you'll see the knees are not translating forward very far, but the hips are going back quite a bit. And this creates a big moment arm for the hips, a smaller moment arm for the knee, so increases strain on the hips and decreases strain on the knees. Let's have you come right back up again, and just exaggerate a squat where you're really bringing your knees forward, okay, as much as you can. Very good. So here's the thing, eventually people run out of ankle range of motion, can't go any further unless you were to bring her heel up, but at least you can see in this example, she's trying to bring her knees forward, and essentially we are increasing the moment arm at the knee, decreasing it at the hip, increasing the strain on the knee, decreasing the strain on the hip. So when we go, you can come on up for me, Kylie, thank you. So when we go from the basic stage of rehab to the intermediate stages, we're going from more of a posterior weight shift to more of an increased anterior translation of the knees, although we're not going crazy. All right, and just as in our first video, we are focusing mainly on the quad and a little bit on the hip with the exercises in this video. Is the calf important? Hamstrings, core, is all that important for knee pain? Of course it is. It's just that's gonna be a discussion for another video, and for here we're focusing mostly on the quad, a little bit of the hip. All right, so the first movement we're gonna talk about is going to be the squat. And two things, we're starting to add a little bit of load. So the way I like to introduce load is usually with a goblet. So go ahead and take that weight, bring it up here, grab the kettlebell by the horns, or if a dumbbell, just holding it under that thick part here, It's actually pretty comfortable. So for the squat, we're adding load, we're also increasing the range a little bit. And the range you have to go through your patient is gonna vary greatly based on what the person is trying to get back to. So for an Olympic weightlifter, eventually we gotta get all the way down. Powerlifter, not so much. For someone that doesn't care about weight training whatsoever, probably not quite as important, right? But generally speaking, I start to go to about parallel or slightly below. So you mind showing me a squat here? We go about parallel, good, and right back up again. That looks phenomenal. The other thing you can mess around with is trying to increase the tempo, so slowing things down a little bit on the way down. Give me about 2 or 3 seconds on the way down, good, and then about 1 second on the way up. Excellent. So when we slow things down, sometimes pain goes down, so try to meet that person where they are in terms of pain. And the other thing I'll often add is going to be a pause. So going to the bottom and pausing down at the bottom there, good, and come right back up again. Yep, and then go ahead and take a breather. So the reason why we add tempos and we add pauses is because it slows down the movement. When we slow down the movement, usually that's a little less strain and feels a bit better for pain problems, right? So one option you can use with your squat to make it more tolerable.
You know, my patients keep telling me that they have pain right behind the kneecap. Hurts when they squat, hurts down the stairs. I think it's patellofemoral pain. What the hell does the research say about patellofemoral pain? PubMed.com. All right, there we go. Okay, excellent. There's 335,000 studies to read. Gosh, too much. I'm getting frustrated. Whoa, calm down. No need to be frustrated. This is Dan Pope. I have fabricated what I believe is the perfect solution to your problem. It is the patellofemoral pain evidence-based cheat sheet. And I'll catch you up to date on patellofemoral pain under 10 minutes. Well, I'll tell you what, Dan, that's actually pretty helpful because I'm kind of dumb and I don't like to read. Well, don't you worry, I'm dumb too. But when it comes to patellofemoral pain, I am not. We're going to go over all the greatest hits. Definition, anatomy, what the heck is the pain generator? Are there any risk factors for this condition? What's the prevalence and clinical presentation? How about mechanisms of injury, differential diagnosis, how you even go about diagnosing this? And then our favorite, evidence-based treatment. So that's my promise. I'm going to get you up to date on patellofemoral pain under 10 minutes. I'll leave a link below in the show notes in the description. Go ahead and click on that link and get to learning.
Next movement I love is going to be a split squat. So we're going to have Kylie go ahead and stride out here. Good. Let's get a little bit longer. Excellent. And from here, I want you to descend all the way down to the floor. Good. And then right back up again. You can take a breather right here. So what we're doing with the split squat is now we're going all the way down to the floor, whereas in the beginner stages, we had a couple RX pads underneath the knee. As we descend deeper, obviously just gonna be a little bit more challenging for the knee, right? And we can choose whatever loading pattern we want. So I can go goblet, I can go contralateral load, I can do two here, two up here, whatever you think is most appropriate for the patient. Once the patient's tolerating split squats really well, we like to make it a little more dynamic. The way we start this is by adding a stride backwards or a reverse lunge. So let's have you take a slight step forward and then go ahead and take a stride backwards and do your lunge there. Excellent, come right back up again. Generally speaking, from a technique perspective, we want to make sure the knee is not coming way far inside of the toe here. We also want to make sure that as we descend, we're not moving completely from one side hip. But in general, if we have a little bit of wiggle room here and there, it's probably not the end of the world. Just keep in mind, folks that have knee pain are apt to compensate. So if my knee feels terrible when I try to do a lunge, my body might say, hey, let's try to move more through the hip, add some hip drop, so you don't have to actually bend through that joint if it kills, all right? So a good thing to keep in mind, if you start increasing the load, you notice a big compensation, maybe regress it a little bit. Next movement I like to progress is going to be our single leg squat to a bench. In the first video, we use a kickstand. So it's offloading the involved side leg with my opposite leg, adding a little bit of balance. For here, we take away that foot. So go ahead and show me a single-legged squat here, bouncing on one leg, reaching forward, yep, and right back up again. If this is too much, it's very easy. Just add an RX pad here. Go ahead and show me one or two. Good, and then relax. And if this is actually too easy, we can add a goblet hold, just like we did for all the other movements. Next movement I really like is going to be a single-legged squat off of a box. So when we squat to a bench, it emphasizes a posterior weight shift because you're trying to hit your butt on the bench behind you. When you do a single-legged squat off a step or a small box here, go ahead and step up there for me. Kylie, very good. And then drop that foot straight down towards the floor. So this movement has more of an emphasis on going straight down, which is going to bring that knee forward a little bit more so, and probably load up those anterior structures a bit more than more of that posterior weight shift in the single-leg squat to a bench. But really good variation to try. If we want to make this easier, we can just go a little bit shorter. If we want to make it harder, raise it up. We can also add load via goblet or any other way. Step ups. I can't talk highly enough about step-ups in general. They also are a great exercise to train for folks that have knee pain or just in general when you're trying to get a bit stronger and more functional for life. So Kylie right here is gonna do a step up, picking one leg up and standing to the top and then stepping back down under control, right? So obviously we can make this harder in the same way as some of the other movements. We go for a higher box, it's gonna make it more challenging, a little bit lower, it's gonna make it easier, and lastly we can add a little bit of weight to make it more challenging too. Next, we have skater squats. This is one of my favorites. A lot of folks haven't heard of these, and I use them all the time for patients in rehab. I like them especially for patients that are returning to some sort of jumping sport. They have to be able to jump and land on one leg. When we do the movement here, keep in mind how similar this is gonna look to your jumping and landing position from a single-legged jump here. So Kylie's gonna stand, and we have a couple Eric's pads here because essentially we're going all the way to the floor extremely hard. So usually start people with 3 or 4 Eric's pads just because it's really tough at first. And as they start to improve, obviously we can go down a little bit closer to the floor. So go ahead for me, we'll go 1 or 2 reps. And what you'll notice is that backside foot does not touch the ground. So it looks a lot like a lunge, except the backside foot never hits. For folks that feel like split squats and reverse lunges are a single-legged exercise, I invite them to try this without putting the backside leg on the ground. It's extremely challenging, but just keep in mind how much this looks like a single-legged jump and landing, which can be a phenomenal exercise for folks trying to get back to a sport. Usually at this point in rehab, we start working outside of the sagittal plane. We start working into the frontal plane as well as the transverse plane a little bit. And the first way I like to introduce some of these frontal plane stresses is going to be via a lateral deadlift and a lateral lunge. So generally speaking, the lateral deadlift is less strain on the knee. If you think about a deadlift, the hips are a little bit more hips back, right? Squat, more knees forward. So let's have you do a lateral deadlift to your left, holding the kettlebell in your hands this way, and take a stride. Very good, tap, and right back. So obviously the knee is coming forward somewhat, but because the weight's in front of you and you're leaning forward, it's a little more hip dominant. Let's do the same thing with a goblet position. We'll do a goblet lateral squat. There you go, lateral lunge, excellent. So in this example, your torso is more upright, knee comes forward a little bit more strain on the knee. A few things to keep in mind. Just because we're moving the frontal plane doesn't mean that's gonna be harder for your patient. So you have a patient that has, let's say, patellofemoral pain or patellar tendinopathy, doing a lateral lunge may not be any more stressful than any other lunge variations. If you have a patient that has MCL, LCL, ACL, some sort of injury where challenging the frontal plane stability is much more challenging, then yes, this would definitely be something that increases the strain, but for some other pathologies, not so much. Another exercise I think is great for intermediate levels of knee pain is going to be a single-legged balance with like button taps on the Fitness Pain Free channel. So Kylie right here is reaching down. She's gonna click on the channel, Fitness Pain Free, and make sure you click a video because we need to make sure we're hitting the like button for a specific video. Very good, back and forth, go ahead down again. Like button there, good. Let's go back and forth. I generally recommend somewhere between 100 to 200 repetitions per leg just because this is so effective, all right? Definitely try with your patients. Now, obviously, these compound movements are going to be really important for your patients, but I will still say if someone has some sort of quad weakness, want to make sure we're isolating that quad, it's important you continue with your knee extension exercises, maybe your partial range, sissy squats, maternal knee extensions, and over the course of time, as their quads are symmetrical strength-wise, you can probably move away from some of these movements. Now that you're an expert with intermediate level exercises, you might still not know the basics. So if you didn't see the video yet, I'm gonna leave this link at the corner. I'm gonna go over my favorite beginner exercises for folks who have knee pain, and I'll see you there.